Hello, all. We will be delving into the need for explainable AI in healthcare through the lens of bias and liability. I am Chong Wei Sao, and you can refer to me by David. This is the DTS 690 capstone presentation. We will be reviewing the AI Bill of Rights as a thought framework to the topics we will be discussing, and that is the challenges in healthcare with focus on bias, how we identify bias and possible ways to address said bias, how explainable AI can work toward addressing these challenges, and how those topics tie into liability and AI in medicine and healthcare. AI Bill of Rights. This is a blueprint set forth by the Office of Science and Technology Policy in the White House to guide society in designing AI innovation through these pillars. First, we want safe and effective systems in place. Any AI ML system which does not guarantee this is not worth implementing. Such systems should be created with foresight of dangers that arise from unintended uses or impact. Unsafe systems in this sense have the potential to scale harm. Second, we need guarantees against algorithmic discrimination. How algorithms are designed and used should not discriminate and isolate categories of subpopulations. Third, there needs to be transparency in the algorithms, and patients and end users should understand the tools that they use or are used on their behalf, as well as awareness of when these AI systems are used. Next, we should reserve the right to refuse use of such systems and require human based personalized care. This ties into being aware of the AI used. Finally, we have data privacy, and within our topic, this falls into the realm of HIPAA privacy rule, which we will not be covering here. Challenges in healthcare. Existing challenges in healthcare and healthcare research are not new, and much work has been done to address this and refine earlier studies that have been shown to poorly generalize because of bias. For example, in studies around BMI, there was a broadly applied classification that patients with a BMI of greater than or equal to 25 will be classified as overweight and in poor cardiovascular health. Asian Americans were seen to lead the population in heart health because of this. However, more recent studies show that this was a false generalization. Studies show that, in fact, Asian Americans were at risk for cardiovascular disease at a lower BMI of 23. And with these adjustments, Asian Americans had no significant difference in overall cardiovascular health. The harm here is that treatment should have been started at a lower threshold in this population. In a similar context, with the Framingham cardiovascular risk score, which performed well in the Caucasian population, did poorly for African Americans, leading to inaccurate care and clinical decisions. These instances of sampling bias in the studies have direct impact on healthcare outcomes. We also find that bias using proxy measurements, where health systems use third party algorithms to manage healthcare resources and patient populations. One such proxy is the use of healthcare costs in correlation to health need. Although overall correlation exists between cost and need, further analysis show that African Americans underutilize outpatient surgical services and specialist services compared to white patients and overutilize emergency room services and dialysis services, of which are instances of greater healthcare need. Reliance on electronic health records. Most of the healthcare research relies in one form or another on electronic health records. However, the problem with electronic health records is that it does not evenly capture data from all groups. There is a problem of data scarcity, and when working with EHR, we must be aware of what data points and what groups are systematically not captured. Another challenge is that many social determinants of health are not captured or captured at high variability. These can be important extraneous variables. To get an idea of the impact, we simply need to understand what these social determinants of health are. An example of the relationship is with patients with poor access to transportation who will not be able to utilize healthcare services or partake in studies. These patients will not be captured in research, and clearly, patients who are unable to access healthcare due to poor access to transportation will have health outcomes that differ from those who are better managed. We must be cognizant of this in our data as it impacts our ability to generalize to underrepresented patient groups. Identifying and addressing bias. Here we look at where bias arises, whether it is data driven, algorithmic, or human bias. We also look at ways in which we can potentially manage bias, starting with awareness, then study and model design, and finally training. Data driven bias. Most healthcare research is done in Western educated, industrialized, rich, and democratic populations, or weird populations. As such, healthcare data is prone to bias and does not generalize well to all groups of people outside of this context. And as previously noted, we commonly see proxy bias and sampling bias in our data. We must choose our proxy features carefully and understand the limitations of each proxy. From the lens of data driven bias, sampling bias has much to do with how the data was obtained or is to be obtained. And we need to be aware when using such data sets that there are vulnerable groups and minorities that are underrepresented and create pockets of data scarcity. We should ask ourselves what groups are not included by the nature of the study conducted. Algorithmic bias. With algorithms, we must do our due diligence to ensure proper model evaluation. With the tools at our disposal, we should consider not only accuracy but also F1 scores, ROC, AUC, and other pertinent evaluation metrics to gauge the performance of our models. We must also consider the bias in our data and decide how we should best utilize an imbalanced data set. For example, through a stratified random split, so that we can account for poor distribution of data across subpopulations. To appropriately perform such sampling, we must also be aware of the features used. We must ask if we lack certain extraneous variables that would prevent stratification or impact model results. And in selecting features, attention is needed on how and which proxies are used. Obermeyer et al. Perform analysis of label choice with total costs, avoidable costs, and active chronic health conditions, and how those impact concentration of Black patients in the highest risk category for illness burden. Of the models explored, the magnitude difference of percentage of Black people categorized in the highest risk category is almost twofold. Finally, we must consider our optimization of models. We should set the minimum acceptable level of loss or residuals when tested for each protected subgroup. This way, we evaluate our models to ensure good prediction performance not only in general, but for each protected subpopulation. Human bias. We have explicit bias, which is clear discriminatory action, speech, and mindset. This is a significant challenge even in this era. However, we do have laws set forth to protect patients from such discrimination. With the Patient Protection and Affordable Care Act, one can file a complaint with the Office of Civil Rights if discrimination occurs on basis of race, color, national origin, sex, age, or disability in a health program. Implicit bias, however, is much more challenging and involves beliefs which can impact actions and decisions unintentionally, leading to biased outcomes. Since they are not intentional and usually obscure, they are difficult to enforce through law. However, these actions can impact healthcare data. As noted by Lindsay Bever, a case shows that a patient was dismissed for being dramatic when requesting a brain scan after months of headaches. later to discover she had a brain tumor. Bever also notes that women with acute abdominal pain are up to 25% less likely to receive strong opioids compared to male counterparts. To address this, we must continuously train our professionals on how to recognize their own implicit bias. And to facilitate this, there is a widely available implicit association test. Black box models. Currently, the best performing AI systems are black box models with better expressiveness, versatility, adaptability, and efficiency. These models lack transparency in how their output relates to their data points. Use of such models will be a liability risk since there is a possibility that recommendations are not in line with decisions made based on standard of care. And such recommendations could hold bias or are prone to error. Also, generative AI, such as chatbots, pose risks to the public as there is increased likelihood people will try and use these tools as low cost personalized medical advisors. Often, these bots are not positioned for such use, and companies often warn against this, and as such, will hold no liability for harm. Creating explainable AI. Trust is necessary for innovation, and where there is no transparency, there is no trust, all of which is needed for integration of these technologies into society. Some notable techniques that can be used to provide transparency into these black box models are feature attribution, concept extraction, influence functions, and model distillation. In feature attribution, we try and see what features have the highest probability of generating a specific output. In the context of computer vision, this is highlighting specific pixels or regions which contribute to model output. To take this one step further, concept extraction attempts to match outputs with semantically similar groupings of input data. This can be seen as an image of a car identified through semantically segmented sections of wheels, car hood, windshield, driver, and passenger side windows. Influence functions attempt to provide transparency by elucidating the influence a particular training point has on model parameters by upweighting such points slightly. Finally, distillation of models is done by utilizing black box models to generate labeled datasets for supervised learning, such as a decision tree. Then we may ask, why don't we just use a white box model, such as a decision tree in the first place? It's shown that decision trees trained directly on the original training data do not generalize as well. Negligence and malpractice. Now we explore the liability piece. In medicine, physicians, as well as other licensed professionals, have responsibility to the standard of care, and deviations from such care can lend themselves to potential malpractice suit. The standard of care is not simply guideline therapy, but also includes treatment that would be patient specific. And physicians must utilize their clinical judgment when working with AI, as they are responsible for potentially erroneous AI recommendations if they deviate from standard of care. The healthcare system also has what is known as a vicarious liability, essentially, liability in this case for the employees of a healthcare system. Legal claims can extend to health system with the basis of negligence due to improper vetting of an AI system, as they have the responsibility to ensure new technologies are properly vetted and implemented. They also have a responsibility to ensure that proper training or retraining and credentialing is performed so that well trained staff are designated for the use of new systems. For example, a sepsis prediction algorithm could be incorrectly interpreted by an ED or ICU physician if not properly trained. Product liability. Here we look at the liability a company has for their product. These companies could be liable for any clear defects in the product impacting its intended use, such as systematically poor outcomes by design, like algorithmic bias mentioned previously. or errors in how the software manages data. For example, one patient's recommendation should not be contaminated by another patient's data, and that there is no breach in data privacy. Other sources of liability could be in poor software or code, leading to bugs, creating unforeseen gaps in proper use or impeding use of technology when a healthcare system has set up workflows which rely on such technologies, and potentially misleading or convoluted user interfaces preventing appropriate use. The courts may be reluctant to extend liability to software developers, as a heavy hand here could impede innovation, and healthcare claims against software companies do not fit neatly into the traditional liability landscape. Traditional healthcare liability falls heavily on the physicians and then the healthcare systems, creating an imbalanced legal responsibility. However, innovative technologies such as AI have the potential to improve care and prevent misdiagnosis, leading to greatly lowered risk of malpractice. To this end, though, we need explainable AI to allow for domain experts and other stakeholders to evaluate these systems because the stakes are high in risk of harm and liability. Health and healthcare are intimate parts of our lives. We utilize medical services with prior assumptions of trust in the physicians and healthcare systems. AI has the potential to improve healthcare quality as well as broaden the coverage of quality healthcare to where it is lacking in society. This potential, however, carries many risks, and we have the right to safe, effective, private, and non discriminatory care, along with the transparency to know when AI is used and the ability to require our individualized care to be handled by a professional without such systems. To be able to actualize these potentials and mitigate the risks, we must have deep domain knowledge to properly assess the bias and shortcomings in the existing healthcare data so that we can produce transparent, explainable AI systems where stakeholders are able to vet and end users are confident in a system's performance. Thank you.